Testing, testing, 1, 2, 3, testing, testing. Dr. Ferrer's mic. 1, 2, 3, testing. Testing, testing. Just give it, you can give it some time. Testing, testing, 1, 2, 3. Test, test. This is second mic test. Second mic test.
Good afternoon, and thank you for being here today. Before we begin, I would like to take a moment to acknowledge our shared grief following the horrific mass shooting in Monterey Park. I'm heartbroken, and I extend my prayers to the families and friends of those who lost their lives, to those who were injured, to the survivors, and to the entire Monterey Park community. We share in the shock, pain, and anger caused by this tragedy, and collectively abhor the senseless violence that affects every community across our county, state, and country. We do pledge to continue to work together to end gun violence in all its forms. During today's COVID media briefing, I'll share some of the positive trends that we continue to see, as well as information and resources to help residents of LA County continue to reduce risks associated with COVID-19. I'll take the next slide. As we begin looking at trend lines, I want to acknowledge that 3 years ago today, on January 26, 2020, we reported the first confirmed case of COVID-19 in LA County and the fourth case in the United States. At the time, we didn't know a lot about COVID-19. We didn't know exactly how it was transmitted, and we had no vaccines and therapeutics to reduce illness severity. Testing was limited, and for the first months of 2020, the only tools at hand were containment strategies, such as distancing and closures to reduce transmission. And as you know, and you can see on this slide, our community has been gravely impacted by this virus. Fortunately, thanks to advances in our understanding of SARS-CoV-2, the virus that causes COVID, and new tools, we are in a much better place. On this slide, we have cases and deaths since March of 2020 and hospitalizations since July of 2020, which is the earliest date available for this particular hospitalization data source. This graph illustrates the ways the virus has changed and impacted our community differently over the course of these last 3 years. The green trend line shows the 7-day average of the number of cases reported daily, and it's measured using the vertical axis on the left. The average number of reported cases is 960, and that is a significant decline from the 7-day average of nearly 2,400 cases that we reported on January 1st. As a reminder, with home testing and people not testing, reported cases give us good context without the complete picture. Many cases go uncounted, and because of this, they're not included in the trend line. The orange trend line shows the 7-day average hospital admissions. This past week, there was an average of 104 admissions per day. This number continues to decline, and it's over 50% lower than at the peak of 211 admissions on January 3rd. The blue line on this slide shows the 7-day average number of deaths reported daily, and it's measured by the axis on the right. We're currently reporting an average of 19 deaths per day, which remains relatively high. We've reported around 20 deaths per day for nearly a month now. It's important that we continue to be aware that this virus is still dangerous and remains a leading cause of death in LA County. I do extend my deepest sympathies to those who have lost a loved one to COVID-19. I hope that you and your families can find comfort during this difficult time. Next slide. Because cases are undercounted, we do look at wastewater data to better understand the level of COVID-19 circulating in LA County. The graph on this slide displays our viral concentrations of SARS-CoV-2 in wastewater from May 29, 2022 through January 14th of 2023. The blue line is the weighted average for viral concentrations across 4 wastewater treatment plants, weighted by the population served at each plant. As you can see from this graph, after plateauing at just under 70% of the summer peak concentration for several weeks, our SARS-CoV-2 wastewater concentration has dropped to about 29% of peak concentration, placing LA County in the low concern alert for wastewater concentrations. The week of October 23rd is the last time this was indicating low concern under our early alert metrics. These numbers confirm that the decline in transmission is both real and significant, and hopefully the decline in transmission will be followed soon by a decrease in deaths. While there remains uncertainty moving forward because the virus continues to mutate, our metrics provide clear evidence that our community immunity level and protective measures have lessened the impact of COVID-19 on many residents and workers in our county. Next slide. Coupled with declines in COVID wastewater concentrations are declines in wastewater concentrations for influenza A and RSV. You can see on this slide that after a quick and severe start to the season, wastewater concentrations for both of these viruses dropped significantly. For flu, there often can be a second smaller peak in the spring, and likewise, RSV will continue to circulate. However, the same measures we've been accustomed to for COVID-19, frequent hand washing, staying home when sick, wearing a mask in crowded places, will also continue to prevent transmission of these other respiratory viruses. Next slide. Using the CDC's community levels framework, which looks at case rates and two different hospitalization metrics, this week LA County remains in the low community level with a reported case rate of 65 new cases per 100,000 people. For the first hospitalization metric, the number of new COVID-19 admissions per 100,000 people, LA County is currently at 7.2. That's down from 9.5 that we reported last week. For that second hospital metric, the percentage of staffed inpatient beds occupied by COVID-19 patients, LA County is currently at 4.6%, and that again is a decrease from the 5.8% we reported last week. As we remain in the low community level, masking for many people in indoor sites is now based on individual preference, unless it's required by the site, including in healthcare settings. That's one of the required sites. It's also required if you're within 10 days of your last exposure to a known COVID case. Masking is also required per Cal OSHA for workers that return to the work site after a negative test on day 5 for days 6 through 10. Please note that masking remains highly recommended for high-risk individuals for those using public transit, or if you've recently tested positive for COVID-19 and you're leaving isolation on days 6 through 10 after your negative test. Next slide. Throughout the pandemic, our surges have often been associated with a new dominant COVID strain. In order to better understand what strains are circulating, each week a portion of positive COVID specimens is sequenced. Maybe you could take that call outside, sir? In order to best understand what strains are circulating, each week a portion of positive COVID specimens is sequenced to determine the lineage that caused the infection, and this can help us better prepare for possible changes in transmission patterns. There is a 2 to 3 week lag in lab data due to the time it takes to sequence specimens. On this graph, you can see variance as a percentage of all specimens sequenced as of January 7th. One important detail we're looking for is a large shift in the percentages of given strains between weeks, indicating that a new strain may be gaining dominance quickly and have the potential to cause an increase in transmission. Currently, we're not seeing these large shifts. BQ.1 and BQ.1.1, represented by the light pink and purple sections in the center of the bars, continue to be the dominant strains, cumulatively accounting for 63% of sequenced specimens. This is down just a little bit. I think it was at 68% last week. At the top of the graph, we're tracking XBB.1.5, represented by the orange bar, and XBB, the yellow bar just below it. In the most recent week, XBB.1.5 accounted for 11% of specimens. This is double from the week before. And XBB accounted for 5% of specimens. This is about the same as it was the week before. Omicron BA.5, our dominant strain during the fall, makes up now just over 10% of specimens sequenced. The CDC does calculate predictions of the estimated proportion of each COVID strain circulating now, given the 2 to 3 week lag in the lab data. For Region 9, which includes California, XBB.1.5 accounts for about 24% of COVID cases. As of now, the proportion of predicted XBB.1.5, as you can see, is not large enough to crowd out the other strains. Next slide. In recent weeks, as schools return from winter break, we've begun to see increases in clusters of cases and outbreaks at schools, which was not unexpected even if community transmission was declining. This is because staff and students spend hours together indoors, and an airborne virus can easily circulate. As a reminder, schools are not required to report every single case of COVID to public health. They are required to report clusters of 3 or more cases in a classroom, office, or identifiable group who were on campus within 14 days before getting sick. The table on this slide shows the number of clusters reported from October 7th through January 21st. If you look at these 2 most recent weeks, you can see that clusters of cases since January 8th have increased. There's been about 119 clusters reported involving 725 students and staff. We are seeing that increase after the return from winter break, with numbers that are higher than any week reported prior to Thanksgiving. However, we're not yet seeing numbers as high as those reported post-Thanksgiving, right away that first couple of weeks after Thanksgiving. Looking at the pattern following the Thanksgiving holiday, where reported clusters and associated cases were highest the 3rd week after return, we do anticipate there may be further increases this month before cases should decline. Next slide. Our department does follow up on the cluster reports, and when our teams find there has been viral transmission on site at a school or at a school activity, that is labeled an outbreak. This slide shows the number of new outbreaks in TK through grade 12 school settings and youth programs from October 2nd of 2022 through January 21st of 2023. You can see breaks in the data for the week of November 20th, Thanksgiving, and winter break, when schools were not in session. Since October, a total of 105 outbreaks have been documented in elementary schools, that's the light purple areas. 26 outbreaks have been documented in middle schools, that's the light blue color, and 21 outbreaks in high schools, that's the dark blue. An additional 12 outbreaks have been reported across youth sports and day camps. After the Thanksgiving break, we did see that outbreaks increase. There were a total of 20 outbreaks open the week of December 4th, and 18 outbreaks opened the following week. This trend repeated itself as schools returned this January. The week of January 15th, there were 20 new outbreaks opened, with 15 in elementary schools, even as our other COVID indicators, as you just saw, cases, hospitalization, and wastewater, are now much lower. This shows how, even in periods of lower transmission, COVID-19 can still be disruptive, and it underscores the importance of basic prevention measures. We thank our many partners at schools who are doing a great deal of essential work to keep students and staff safe, and we do recognize the difficulty of the disruptions that come with the COVID outbreaks. Next slide. To help reduce COVID-19 in schools, students and staff should stay home if they have any symptoms of illness. Sneezing, coughing, sore throat, they have a temperature, body aches, or they're being unusually fatigued. Since early November, over 2.6 million test kits have been distributed to schools by the county, and both students and staff should test if they have any possible symptoms of COVID-19 before they come onto the campus. To prevent outbreaks, testing is also essential after a COVID exposure, or if a person has recently participated in a very high-risk activity, traveling or attending crowded indoor events like concerts. If someone has been exposed to COVID-19, even if they test negative, masking is required for 10 days after the known exposure. Further, that high-quality, well-fitted mask can help to prevent transmission, and I do encourage people to continue to think of masking as an effective tool to reduce exposure to COVID-19. Last, to reduce COVID-19 disruptions in schools, all students and staff are encouraged to get the updated bivalent booster if they have not done so already. The bivalent booster has been approved for all children over 6 months of age. Next slide. We do continue to stress the importance of COVID vaccines because various studies and clinical data provide mounting evidence on the effectiveness of the bivalent booster at reducing the risk of symptomatic infection and severe illness. I want to share local data on vaccine effectiveness that correlates well with the research findings. On this slide, we see the hospitalization and death rates over the past 30 days for LA County residents who are unvaccinated compared to residents who are vaccinated without the updated bivalent booster and to residents who are vaccinated with the updated booster. And while this data has some limitations, it can help us understand differences in hospitalization and death rates that are associated with vaccine coverage. The yellow graph is hospitalization rates per 100,000 people, and the blue graph is death rates per 100,000 people. Hospitalization rates as part of the 30-day period ending January 10th were over 3 times higher for people who were unvaccinated compared to people who were vaccinated without the updated booster. For those vaccinated without the updated booster, their hospitalizations were 2 times higher than for people who had additionally received that updated booster. Overall, people who were unvaccinated were more than 6 times more likely to be hospitalized compared to people who had had the bivalent booster. It's sobering to look at the same comparison for death rates for the 30-day period that ended January 3rd. People who were unvaccinated had death rates that were about 3.5 times higher than for people who were vaccinated without the updated bivalent booster. And for people who were vaccinated without the updated booster, their rate of death was more than 2 times higher than it was for people who had received the updated bivalent booster. Unvaccinated individuals were more than 7 times more likely to die than those who had received the bivalent booster. While vaccines are not a guarantee against severe illness and death, this data illustrates the very real protection offered by the bivalent booster and by vaccines, even against the newer variants that are circulating now. And preliminary findings reported this week by CDC from a clinical study draw the same conclusion. The study findings show that the bivalent booster provided additional protection against symptomatic XBB and XBB.1.5 infection for at least the first 3 months after vaccination in persons who had previously received 2 to 4 monovalent vaccine doses. People often mistakenly think that they don't need an updated protection because they've been previously infected with COVID, or they don't realize that they're even eligible for the updated booster. If you haven't had a booster for COVID since August of 2022, or if it's been more than 3 months since you had a COVID-19 infection, it is time for the updated booster, and this data helps us understand that it does provide increased protection. Next slide. Even with vaccination, we're all aware that there's still the possibility of infection. And while for many symptoms are mild, others do require hospital care. Since remaining in the low community level is dependent on keeping hospitalization rates low, we're grateful not just for tools that can be used prior to infection to reduce risk, but for the COVID treatment options that can be prescribed before symptoms escalate. Seeking therapeutics, these medications against COVID, as early as possible after symptoms have started can help prevent severe illness and death, particularly for those with underlying risk factors, which includes many common health conditions. Underlying health conditions that put you at higher risk include diabetes, hypertension, hyperlipidemia, chronic lung disease, asthma, stroke, kidney disease, liver disease, dementia, a history of cancer, or immunosuppression, among other things. If you test positive for COVID or you have probable symptoms, it's always good practice to check in with a provider to see if you're eligible for treatment. I believe that many more people are eligible for treatment than those who think they are. 3 options are available. In early clinical trials, these treatments were shown to have a high efficacy rate. That means that they were over 80% effective in reducing hospitalization or death. Paxlovid is for adults and children 12 years and older. This medication is taken orally at home, and it needs to be started within 5 days of symptom onset. Similarly, molnupiravir is also taken at home in a pill form, but it's indicated for adults only. Like with Paxlovid, if taken within 5 days of symptom onset, it's effective at reducing the likelihood of hospitalization or death from COVID-19. Remdesivir can be administered to adults and children as young as 28 days old. And like all of these medications, it needs to be administered as soon as possible, in this case, within 7 days of symptom onset. This medication is delivered via an IV, and it needs to be administered at a healthcare facility across 3 consecutive days. You may notice a trend here. The key is speaking to a provider and starting these medications as soon as possible if you have symptoms. And I encourage everyone to do so and fully utilize the resources that are available in LA County. Next slide. If you test positive for COVID-19 or you suspect you have symptoms, there are options in LA County so that you can receive medical attention as soon as possible. As of January 24th, there are over 1,100 sites in LA County where a person can obtain these therapeutics. And of these, 139 are what we call test-to-treat sites. Test-to-treat sites are places where you can be tested for COVID-19, speak to a healthcare provider, and if you're eligible, you receive a prescription and the medication itself all in one place. As you can see on this map, the gray dots are locations to fill therapeutic prescriptions, and the pink dots are your test-to-treat sites. A full list of these sites is available at our website, ph.lacounty.gov/COVID medicines. I do want to recognize, and if you look closely at this map, you'll see that there are places where healthcare resources are scarce, and that may discourage people from seeking COVID-19 treatment. It's essential that everyone know that we have some additional options. The next slide. In LA County, we have the Public Health Call Center. It's open 7 days a week from 8 in the morning to 8:30 at night, and it can answer questions about COVID, and most importantly, it can provide free telehealth services for all LA County residents. And this includes prescribing COVID-19 therapeutics if it's the right option. The number is 1-833-540-0473, and the services are offered in multiple languages. This service is available to make sure that all residents can access therapeutics in a timely way, regardless of where they live, their immigration status, or whether they have insurance. If you test positive for COVID-19 or you have questions about COVID-19 symptoms, you can be connected with a provider at no cost. When you call, a nurse will ask about your symptoms and related health issues. Next, you'll get connected to a physician who may prescribe either Paxlovid or Molnupiravir, depending on what makes sense for your particular case, to treat your COVID-19 infection. And both are medications, as I noted earlier, that you could take at home. If you're prescribed a treatment by your telehealth provider, that treatment will be shipped to your house overnight for free. Next slide. Telehealth services can make a difference, especially for those who live in areas that provide less access to healthcare resources. From April to December of 2022, over 6,300 people in LA County accessed telehealth services. And in doing so, more than 5,300 people received a prescription for therapeutics to treat COVID-19. On this graph, the blue segments represent the percentage of people who called the telehealth line, inquiring about therapeutics, who live in zip codes that have been identified by our public health department to be most vulnerable to poor COVID outcomes, either due to socioeconomic and environmental conditions or low vaccination rates. Overall, as you can see, more than 58% of the people who called the telehealth line for therapeutics were living in communities where residents were at higher risk for poor COVID outcomes. In closing, the use of therapeutics, reasonable precautions including masking and testing, and access to the bivalent booster have all helped to put LA County in a really good place right now. This afternoon, there will likely be news from the FDA about updated booster recommendations, changes that would likely take place next fall and help our country remain prepared and protected for future transmission of COVID-19 variants. For right now, we're blessed to have the tools that make a difference, and I applaud everyone for using these tools to dampen spread and reduce risk, especially for those most vulnerable. For those at elevated risk who have not been boosted since August, please don't delay adding in this additional protection that's offered by the new bivalent booster. I'll now take your questions.
Marla Tejas, Fox 11, you want to start us off?
Sure. Okay. Please, thanks. Dr. Berg, I wanted to
follow up with the our conversation last week about counting COVID deaths.
Yep.
And your statement 10 to 20% potential overcount. I did reach out to, this follow-up is because I did reach out to California Department of Public Health. Okay, so they gave me a statement, a lengthy statement about this. I don't want to get this wrong, so I'm going to read this to you. It says that they're currently planning implementation of a new statewide death guidance that aligns with the most recent definition, and they cite the Council of State and Territorial Epidemiologists.
Yep.
This has been discussed with local health jurisdiction partners, and CDPH has recommended to implement the new definition for deaths occurring as of January 1st of 2023 this year. CDPH does not recommend that the LHJs update.
Local health jurisdiction.
There you go. Update the classification of COVID deaths based on the new guidance for deaths that occurred prior to January 1st. So, if
we don't have the definition yet.
You don't?
No. I mean, we do. This has not been finalized, so
Okay.
I'm really glad you were able to reach out to CDPH, and we, as I indicated last week, once there is a new definition, we'll do exactly what CDPH is recommending. We'll go back to January 1st. We'll use the definition, whatever it ends up being. We'll use that definition to classify deaths.
Okay,
But just like CDPH is saying, and we concur with that, it would be impossible to go back further in time and start trying to reclassify all the other deaths.
Okay, so if that does happen, for instance, I went ahead and counted the
yeah.
number of deaths in January thus far.
Yeah.
I don't know today's daily death count, but up until today,
Yeah.
it was
Today was 23.
23. So that
Sorry.
brings it to 625 deaths in the months of January in LA County. So if it were 20% overcount, then we would subtract about 130 deaths.
Yes. But again, we need
Okay.
to get that definition so that we actually give you, as I said last week, it could be anywhere between 10 and 20%. Without the final definition, it's really hard for us to assess the changes. Some of the changes that they have been discussing might increase slightly the number of deaths, and some of the suggestions might decrease the number of deaths. So, if everyone can just have some patience, as soon as we get the final definition from CDPH, the California Department of Public Health, will go ahead and make the adjustment.
Okay, and then the week prior, we talked about overcounting potential COVID hospitalizations and just the difficulty in that because it's so nuanced.
Yeah.
Is your department doing anything just to get better data from local LA County hospitals so that there isn't such a big difference?
I think the issue at this point in the pandemic is the reporting requirements for the hospitals have to be linked to the purpose for which we're using the data. Most hospitals are comfortable with the idea that, we do the two things we do now. We use the definition that CDC has for counting all hospitalizations where people have had a positive test, knowing that for some of those people, it might not affect their care at all. Mm-hmm. For many of those people, it might affect the care. And then being transparent by reporting out, and we do it every month, what proportion of the admissions, so it is at the point of admissions, what percentage at the point of admissions of cases are people who are there because they actually are sick with COVID-related disease or people who just tested positive.
Okay. And if I may, so we're at the end of January. Next week, LA City's COVID emergency ends. So does the state's next month as well. How do you see your role evolving? What does that mean for LA County Department of Public Health?
I think you've seen all along that as conditions change, we adjust our response accordingly. Some of the activities that we've been doing won't be as necessary. Other activities will continue. Obviously, everyone wants us to be transparent with all of the data and the information, tracking the variants, doing wastewater concentrations. There's a heavy emphasis now on sort of early alerts. We introduced that notion to all of you, back last summer. But everyone's anxious to have those early alert systems in place. So I think there'll be an emphasis on really identifying, are there other possibilities for early alerts as well that would help us, use our masks when we really need to use them, not use them when we don't really need to use them, make sure that we have capacity to provide services and support as people need them, and when that need increases, that we're set up to do that, and always continue to have capacity. I mean, the areas of focus will continue to be to make sure there's easy access to vaccinations, testing, and therapeutics. That's still at the very core of making sure that people can protect themselves and can help protect the rest of the community.
Dr. Ferrer, 3 questions from Ron Lynn at the LA Times. I'll start with the first question. How would you advise people on whether they should continue wearing a mask in indoor public settings? And can you talk about your own decisions on masking and eating in indoor public settings?
Yeah, thanks, Ron. I think our guidance is pretty clear. You know, there are some indoor public settings where you're required to wear your mask. That's all healthcare settings, congregate care settings, and any place where a business or school wants you to wear your mask. So I'm going to ask that everybody please comply with those directives. We've also continued to strongly recommend that people who are more vulnerable for severe illness, you know, keep those masks on, particularly in those indoor settings, and you know where they are, that they're very crowded, the ventilation may not be great. We encourage workers who are going to have many exposures during the day to go ahead and keep those masks on, because transmission, while it is much lower, it's not. We still have transmission. You can see that on all of our slides. And this is, again, particularly true for people who are more vulnerable or who live with people who are more vulnerable. One issue with workers is they don't want to take it home to their families. And, you know, I think our guidance is clear. You know, I think for individual people, including me, you know, I assess the situation. For the most part, I keep my mask on as much as possible indoors. But I do eat at restaurants. I do go out to people's houses. Mostly we still test beforehand if there are questions. But again, I think I'm an older person. You know, I'm over 65, and I don't want to get sick.
Ron's second question here. He says you mentioned that you think the daily death number for COVID-19 is high. Ron wants to know what level you want it to be at before you consider it medium or low.
Yeah, that's a great question, Ron. I mean, I would say, you know, there was a time where we were, you know, averaging between 5 and 8 deaths a day. That's still more than we see for many other diseases, but we would be a lot more comfortable if we were getting down closer to 5 deaths a day. It doesn't mean that the risk has disappeared. Obviously, that will still be that over, you know, 1,500 deaths, well over 1,500 deaths a year, still be, you know, a cause of death that's you know, difficult for people. But that to us would be a much more stable number and would indicate that our protections are really working extraordinarily well. You know, again, I like to think of us getting to a place that's similar to what we see with other respiratory illnesses, like influenza. I think, you know, with both influenza and with COVID-19, for those of us in public health, these are vaccine preventable deaths. So we're always going to want to get the number as close to 0 as we can. Because as we've seen, while the vaccines aren't perfect, they continue to provide a lot of protection. So part of the effort I know needs to be to make sure people have good access and good information about vaccines and boosters. I'll take that last question.
All right, let me pull up his third question. The FDA halted its authorization of Evusheld. Are you concerned about that?
No, I mean, I appreciate, I'm not concerned that they halted the approval. I really appreciate that our scientists continue to sort of stay up to date. If a medication is not effectively responding to a particular disease, or in this case, a virus, then we really need to make sure that all of our providers are well aware of that and that they're not using a medication that's not known to be effective. But I am concerned, as we all should be, that as the virus mutates, we have to continually reevaluate our therapeutics and our vaccines and our tests to make sure that they're able to do the job that they were set out to do.
A next question here from Jackie Fortier at KPCC. Should large employers in LA continue to require COVID vaccinations as a condition of employment? And does it matter at this point?
Well, it always matters. that we encourage people to get vaccinated. I mean, this is, again, a vaccine preventable disease. The vaccines work extraordinarily well. So it's very important that people have good information and go ahead and take advantage of a protection that we have in the United States, and that's easily accessible. I think decisions about whether or not to require vaccinations at particular settings really depends on the nature of that setting and the business. You know, certainly we're in healthcare and we require our employees to be vaccinated for against a host of illnesses and diseases, and we also require certain screenings. So I'm well aware that in some fields it's more important than others.
Okay. Follow-up questions from Ron Lynn. You just showed how the death rate for unvaccinated people is so much higher than vaccinated people. Are these unvaccinated people mostly those who were never infected before, or are they mostly people who have been infected before?
I mean, we use the data from all the from all the county residents. This data represents sort of the denominator is county residents. So it includes both unvaccinated people that have prior infections, maybe even more than one, as does the vaccinated data include them as well. You know, given that the vast majority of people in LA County probably have been infected at some point over the course of these past 3 years, I would anticipate that many of the people that are still unvaccinated have in fact been infected as well.
Okay. In that same vein, he asks, do you find that unvaccinated people, even if they've been infected before, are at a higher risk of death if they get a second infection?
Well, we don't have data ourselves that actually has analyzed that, so we're going to rely on the couple of studies, particularly the VA study, that indicated that there was increased risk with second and third infections.
Okay. Another follow-up from him. Any other thoughts on why we're seeing a relatively mild winter? For instance, we stopped talking about herd immunity long ago, but are we actually starting to get there?
Yeah, I mean, I think the level of immunity, I've noted that in, you know, pretty much over the last month, that level of immunity matters. We have it because lots of people have been infected, and we have it because lots of people are vaccinated and boosted, and it matters. We know for sure it matters. Even as we get new strains of the virus, if they have a limited pool of people that can get infected, it's going to dampen the transmission that we're seeing.
Oh, Ron wanted to clarify, when you dine at restaurants, are you eating indoors or outdoors?
Well, everyone knows I love to be outside, so mostly I try to be outside. But no, I go inside when that's not an opportunity.
Okay.
So.
The updated bivalent rate?
We are at, for the county, I want to say 22, maybe it's 23%.
Because last week we were at 22.
Yeah, so I think we're at about 23%. I don't have today's update yet, but I think we're close to 23%. The really good news is the rate that increased was amongst people 65 and older, where we're just about at 40%. So let me verify what the number is for the general public. I'm tracking, you know, on an almost daily basis what's going on with older people because there's so much more risk. And I'm very pleased to see, you know, we were at like 35%, that we've gotten a big bump up, and it's close to 40%. And at our nursing homes, we're about at 66%. So in both places, we're making some progress.
I'm surprised that you dine indoors because you're such a proponent of the mask, and given the weekly briefings.
Yeah, transmission is much lower. I keep my mask on unless I'm eating or drinking, and I go to places that I feel like the ventilation is decent.
And you still you still have remained COVID-free.
I have, as far as I know, remained COVID-free, and just to let folks know, I test at least 2 times a week. So.
So what do you attribute the just natural decline to? Do you just, without having to put in that mask mandate?
I think, first of all, I think people were using a lot of protections themselves. I mean, I've talked to a lot of people who were frankly very nervous with the configuration that we were seeing, you know, back in the fall, where we had RSV, we had a lot of flu, we had a lot of COVID, lots of people were sick. Their travel plans were getting disrupted. So I think a lot of people realize that they can take their own steps and that those steps are pretty effective. That reduces their own risk, but it also reduces the risk in the community. I also think, as I noted with Ron's questions, that we have a fair amount of natural immunity, and that really is helping us avoid what we saw in earlier surges. And I think the third thing is what we're seeing now are new strains of Omicron, not new variants. We have done our very worst when we have gone from one variant to another. We went from Delta to Omicron, and Omicron devastated us that first winter. So my sense that we had Omicron. So my sense is that our bodies have more, first of all, we know our vaccines are effective against Omicron. They're working really well. Some of us have been infected with Omicron and have some natural immunity. That combination, I think, is really helping us this winter as well.
I read an article today titled "COVID-19 is no longer a public health emergency." This is from a acclaimed epidemiologist.
Yeah.
Do you agree with that?
I'm always troubled with the word emergency because I think it means different things to different people. To me, I would use a definition of emergency that really allows us to classify increases that we're seeing in preventable diseases as, there's an urgent need to continue to act. But we are nowhere near the emergency we were at before.
Okay. And then last question, just to follow up on when can we expect the updated count for COVID deaths? Do you know?
I have no idea. I mean, I'm assuming that the state is, working through their review processes. I mean, these all have processes for review. And once that they complete that, then we'll go ahead and be notified, and I'll notify all of you, and the state will notify you as well.
Thank you.
Thank you.
I have no more emailed questions either, Dr. Furr.
Okay. Thank you. Thanks, everyone.